Good morning, everyone. Welcome back. And I'm Damdi Wongya, publication in charge. I will be moderating the fifth session and bringing diversity into practice. So I hope you all had a good refreshment during this short break. So I look forward to have a very interactive session. So for this session, I would like to request Dr. Navidita ji, founder of Earth Counseling and Art-Based Therapy, to kindly chair the session. And I would like to welcome our speakers, Dr. Lakshmi Ravikant Kodin, Bain Academy of Leadership and Mental Health, and Dr. Deepak Gupta, founder and director of Center for Child and Adolescent Wellbeing, New Delhi, and Dr. and Mrs. Ragni Chopra, accredited professional counselor, London. So I request all chairperson and speakers to take your respective seats. So obviously we know very well Dr. Navidita ji, and by now, so without taking much time, I would like to request Dr. Navidita ji to kindly proceed the session.
Thank you. Since yesterday, we've heard diverse perspectives, theoretical frameworks in mental health. And since last evening, we've also started seeing how these views engage in the field in terms of practice. Today morning also continued with an integrated view and practice models. It gives me great joy to share this panel with three wonderful speakers and practitioners. And the title of this panel is Diversity, bringing this diversity into practice. So what we are going to hear is about rehabilitation, about a biopsychosocial-spiritual model, and also about use of assessments for recommending therapeutic interventions, so that as our takeaway, we are able to kind of recognize how does one use all of these views when we are with our clients. So we'll begin with Dr. Lakshmi. Dr. Lakshmi is a PhD in applied educational psychology. She has a master's diploma in psychological counseling from CCC Vellore. She's also a master's in education and literature. She's taught applied psychology for 5 years in Osmania University, Hyderabad, and she's currently co-dean of BAM. So while her introduction is written in the program schedule, there's something else that I would really like to share. Dr. Lakshmi wears many hats as a counselor, as a teacher, as a researcher, and also as an administrator. And she does all of this with equal excellence. She's been working across 3 decades. So also she's an expert in terms of seeing changes and trends in the mental health sector. Welcome, Lakshmi.
A very good afternoon to all of you present here. I start my brief talk with my deep gratitude to particularly the Tibet House, Geshe ji, who's been my teacher, mentor, and guide, Nivedita, again teacher, mentor, and guide from Earth, all you esteemed panelists whom I've been listening to since yesterday, lovely young faces and students and members of various institutions and civil society. I would also like to spare a few seconds in my own heart to pray and to thank my parents, all my well-wishers, my organization, and all the people who loved and cared for me to be present here. I owe deep gratitude to them. Um, the presentation that I have is probably not going to be very different or unique, but I probably will leave a lot of us here with more questions than answers. I come as a as a trained and a practiced psychotherapist. But today I don't see my role as confined to psychotherapy anymore, considering that I have been here for 35 long years and I wish to continue my service. So I think this is a profession of service. And with not everybody is endowed with this opportunity to meet with these challenges. And I work in an organization called the Banyan, which has a very brief history of having begun its tiny steps 28 years ago by two very fabulous women who are my friends today. I joined them 3 months later in December of 94, and I never looked back. And I don't want to look back. We only look ahead. What we do is while the topic is diversity, while the topic I'm talking to all of you about is rehabilitation, reintegration, we really started with no strategy, with no program. It was the response to a need of two young girls, two women on the streets, not knowing why they're so often found on those streets. And the inquiry began with just curiosity. And the curiosity then led to something that we today call ourselves the Banyan, where we work with homeless, mentally ill, and the marginalized. The poorest of poor of women drawn from the streets, and street is no home to anyone. Now we have expanded, again without a plan, to offer our services to men, women, as I already said, children, and anybody who is rendered homeless. And we don't know, we are still trying to find out through research and other expert opinion whether mental illness causes homelessness among the poor and the marginalized, or it's the vice versa. But this is a nexus. And very often, not wanting to, people move away from the center to the margins. And to bring them back from the margins to the center is a utopian and ideological concept. It's read about, it's chronicled, it's researched and written about. But how many of us have actually seen people who are invisible become visible and become, part of what we talk about in terms of integration as an integrated, inclusive, part of the community. So I would actually say that I'm a community mental health worker. I like to call myself not as a psychiatrist or a psychologist. I'm a mental health worker, and I'm also a social worker, all rolled in one. Sometimes I'm also a policeman on the road. Yeah, so, but this is a role that, it's very enchanting because you realize what, as we all said, and Geshe-la always reminds us, that you have the potential. You have the seed. Allow it to grow, allow it to germinate, and it will. I'm not very good in technology, so I don't know what I'm pressing. Hopefully, it'll take us to the next slide. While she showed me very kindly, yes, I'm successful. That warrants a clap for me. So, without going into statistics, we are talking about the burden of mental illness in India, which all of us have spoken, and we said we really don't need to go there into statistics, do we? We know the enormity of the problem, and the numbers don't make it any better or worse. But having said that, I'm just showing you something that, yeah, there are people experiencing mental health issues, and most of them are the marginalized. Most of India, we have people living on less than $2 per day. So I think we are all very, very grateful and privileged for the kind of lives that we lead and the kind of help that we can provide. So we are not looking at rehabilitation from a very textbookish concept. It is a concept, no doubt, but it cannot be a concept unless it's articulated on the ground as a reality. Reintegration is a multifunctional reality that it totally spans across several layers of cognitive, affective, connotative, and social skills that the person living with mental illness needs to feel I'm enabled to be included. First of all, who excluded them? Nobody intended. We don't know how they got excluded, but now we talk about inclusion. Like we are giving them something, but they already had it. They're part of us. And then for us to say we want to make them contributory members of their family and their community. They always contributed. They always were a part of a family, like you and I do. So the holistic healthcare model that Banyan follows, our basic trajectory is across most systems of mental health care. Structures are not at all rigid, and we completely believe in a flexible approach. So we do not work in silos. We don't work in isolated pockets. And like somebody said, we do follow the biopsychosocial spiritual model of care. And that is not rendered by one person. Mostly these are rendered by psychiatrists, social workers, lay mental health workers, nurses, panchayat people working in the community, ASHA workers. So anyone and everybody is welcome to join the fraternity of helping people rehabilitate. Rehabilitation for you and me is not just going back to something or to restart something. The word re connotates that you're going back. I would think we are going ahead, right? So this is the quick care model, and I have just 5 slides. Therefore we have a model called the emergency care and recovery services, which is called the ECRC world over. So we have a 150 bedded hospital where we only work with people who are on the streets. And because it is not easy to get somebody off the street, particularly with a mental health issue, without the friendship of police and legality. So we need reception orders, we need to work with law and to do lawful abiding ethical practices. So we have a rescue and admission center where a lot of other illness interventions, psychiatric interventions, social interventions are part of the treatment process. So rehabilitation does not start after illness or recovery. It is during, as soon as they enter, we are thinking of rehabilitation. And then we have simultaneously, so this is not a linear trajectory, simultaneously we start working with psychosocial interventions. And who are we working with? The length and breadth of people who somehow have landed up in Chennai through trains, through buses, through, various means, not just Chennai, but we had people from Nepal, Bangladesh, Sri Lanka, who are found wandering on the streets of Chennai. Today, our services are expanded, so we work in the length and breadth of the country. And it's just, for me, geographies don't matter. We work with people, in Assam, we work with people in Bihar, we work right now with people in Uttaranchal, Delhi, wherever there is this whole homelessness, mental illness, we work there, we go there. This whole thing of, we all think it's important to get them back to doing something as they're getting better, so vocational training. And then the important criteria is looking for readiness for change. How does a person who's rendered homeless and does not have an idea where to go, where the home is, who the family is, get back home? That is where a challenge begins. And if you do find a home, quote unquote, There are many, many reasons why they may not be able to go back home. For the fact of lack of receptivity from the family or the community to take them back. Sometimes interesting stories like our women get so pampered in our ECRC that they go there and they say, we don't want to stay here because we don't have an English commode. So we want to come back to the banyan. So we've had those kind of stories. And sometimes people think, no, she's come back, she's well, we love her, we'd love to take care of her. But what about the other siblings? They won't get married, because it's mental illness. So can you take her back? And once you have brought somebody out of a psychological and a social cycle of vulnerability, being in a homeless situation, you cannot leave them without a roof and safety and security. We are obliged to provide that. So the readiness then starts with a lot of things, and I'm going to quickly share a case study. Then this is the programmatic thing: discharge, reintegration, and lifelong aftercare follow-up for treatment continuation. Lifelong. Medicines, food, all other social care benefits, we don't leave them. They don't leave us. So this is the Banyan Quick model of care, which is, we call this a social justice lens to mental health care, because we cannot provide mental health care without the length of rights, lens of human rights, dignity, worth. So this is a social justice lens. So we do have promotive care services, which I'm not going into, which has its own focus. We have reintegration services. We have the flagship program Home Again, and which I'm going to talk to you about quickly or show you a film. And then we have what is known as, it is not just to tackle the effect, we have to tackle the cause. So prevention of homelessness through our Center for Livelihoods in Mental Health, where we create outpatient services. We have what is known as Nalam, in Tamil means well-being workers, the community foot soldiers. Somebody was asking a question: how do students, how do volunteers, how do people who are not professional want to go and do something? This is a kind of a model that we have created. Then we work with innumerable stakeholders, because you can't work in isolation. And we have livelihood options. We have all across the country stakeholders with whom we do stakeholder operations, aftercare services. So anyway, all the while, the numbers again don't matter, but Tamil Nadu alone, we have helped, rescued, rehabilitated more than 8,000 persons, which is a very minute number. It's not a number to be proud of, honestly. This is a number that needs to be worked upon vigorously. So that's the Banyan. And in the center, you'll see the Emergency Care and Recovery Center. We start clinical time interventions, safety planning, harm reduction. You welcome the individual, you engage with the client, not from a psychotherapeutic point of view, focus on social role valorization, pre-discharge, stay in recovery hubs. Then we look at reintegration and aftercare. When we are doing that, what do we have? You have an inclusive living home option for them. We have pre-engagement and introduction to a home again approach. We have a setting up of a home, and we have continuation of your daily activities. If that doesn't happen, they go back to their homes in a community. Then you have the Nalam, the well-being workers, who will be doing entirely from the time they go, the entire social mapping and distress mapping, and enabling different health-seeking pathways. We engage with the client, we restore their health and identity, we pursue personal recovery like the way they want it, not the way I think is your personal recovery. We look at the continuity of care. Is this continuity of care? And we look at beyond ill health narratives. What is the continuity of care that we are talking about? You cannot cure a population only by treating the cause of what's going on. We have found that you give them social entitlements. So somebody goes back and there's a community, and then they have something like, what do they have? Ration card. They want Aadhaar card. They want voter identity. Now this is their identity. We have to give them that identity. Thank you. We have 5 more minutes. And therefore, I skipped the case study, but I'm going to tell you that we have a very huge aftercare package, which facilitates with the resident with entire thing with the discharge committee, approvals, family visits. So it's a very long drawn, continuous process that happens. And yeah, so this is it elicits what all happens, how you look at client history before going, post going, looking at the family, looking at all the details that are going on with the client, where the client is at various points in time of their life. So reintegration is not an entirely a one point process. May I now just show you, can I just show you that 3-minute film? Before the film gets on, I'd like to ask all of you, where are you going today after lunch? Yeah, but sleep where? Here in the hall? Yeah. So all of us have a home to go back to. Whatever that home may be, a hut, it could be a shed, it could be a bus, it could be a beautiful house like I have one, it could be a even more beautiful house like some of you may have, right? We have a home to go back to. What about the homeless? What is the home that they will go back to? And I'd like to show you this, which is our flagship model, and it's now being adopted by various governments of India. And I stand here in humility when I'm saying that, not pride, but the fact that the work is getting recognized, the fact that people reckon with the fact that people need homes, and we need to provide homes for the homeless and the mentally ill and the most vulnerable. This is not my fault. I'm biding time. So you have to give me 2 minutes more because they're trying to fix the video. I'm trying to be clever. Yes, yes, yes. So I'll take leave and say thank you, and I'll go back and sit while you watch the film and just absorb it. Thank you very much.
Once again.
Wow. Just immensely moved, Lakshmi. Thank you for sharing that with us. Thank you for sharing the story of Banyan, because clearly it's a story of courage and intention and moving forward, like Lakshmi said, without necessarily clear strategy, but saying there is a need which must be addressed and using all tools necessary. And when we thought about bringing diversity into practice, in some ways, it sounded like bringing diversity only into mental health practice. But I think this presentation's also highlighted how it's not just bringing in diverse perspectives in psychology, but really mobilizing social systems, government machinery, and processes. What what Banyan calls the social, using the social justice lens in mental health care. So really, really precious. Thank you very much. Now, I'd like to invite Dr. Deepak Gupta, who's going to speak about the biopsychosocial spiritual model of mental health. Dr. Deepak Gupta has a long and esteemed career. He began his academic training at the Kempegowda Institute of Medical Sciences, completed his MBBS, and then was a gold medalist in an outgoing psychiatry resident as part of MD in Manipal, after which he's completed his DNB in psychiatry as well as diploma in child and adolescent psychiatry from the Institute of Psychiatry as Maudsley King College. He served as a former consultant for child and adolescent psychiatry at the Indraprasth Apollo and has continued to serve as a senior consultant at Gangaram Hospitals in 2004. He is also founder and director for Center for Child Adolescent Wellbeing, which is based in GK, New Delhi. He's conducted and organized multiple workshops and conferences. What I would like to add, which is not in the bio given here, is that in the field of mental health, he's really well known for his dynamism and open mindedness, which has really led him to be an inspiration for many budding mental health professionals. Dr. Deepak Gupta, we're very happy to have you with us. Thank you for your time.
Hello and good afternoon, everyone. It's 12:30. So, and first of all, thank you to the Tibet House and Dr. Nivedita for giving me this opportunity. It's an interesting topic, a topic which is very close to my heart, which is usually not addressed in the mainstream mental health field, which is usually you don't see usually in the conferences, usually in the normal conferences. And it's very close to my heart because I practice every day. I'm a part of Raj Yoga, and I'm in the Gyan for last many years. And every day I go to my Raj Yoga Center, Brahma Kumari Center, and practice every day part of it. And this is almost last 6 years I've been into it. And why I got more and more interested into it, after working day in and day out with a lot of children with multiple disabilities, autism, ADHD, intellectual disabilities, adolescents, adolescents with self-harm, multiple self-harm, suicidal ideations, no context of living. There were a lot of things which were coming into my head. And there were no answers in the books and textbooks. There were no answers from professionals. There were no answers from professors. There were no answers from your contemporaries. And gradually, one day I was invited for a talk in Brahma Kumari Center, 17th May 2015, by one of the parent whose son has autism and is under my care. And she forced me to come there, and I went there. I never thought of that will be a starting of a new chapter of my life or a new paradigm shift in my life. And from next day, 18th May 2015, I was into that Raj Yoga or Gyan, which is also called as the spiritual enlightenment and spiritual learning, which is part of my everyday learning. I don't start my day without that. I don't end my day without that. And that has really helped me in my practice. That has really helped me to understand myself. And I want to make reach to more and more people that as a mental health professional, a psychiatrist, as a child psychiatrist, I don't practice with adults. I feel adults are too complicated for me. So I only work with children. less than 20 years of age. And I enjoy every child with which I work. I enjoy every moment of my life and my work. And that's what I've learned. So I'll reflect some of these thoughts with some theoretical backgrounds. My colleague, Dr. Nebunita, who's a fellow with me at Gangaram Hospital, has helped me to put some of the slides as usual. Now, the biopsychosocial. Whenever we go to talk about any model in mental health, this is something which crops up. Biopsychosocial model. Very, very clear. Bio means biological, psycho means psychological, social means social. And we put all of them together. So it becomes biopsychosocial model. See, biopsychosocial model is an interdisciplinary model that looks at the interconnection between biology, psychology, and sociology, environmental factors, and examines how these multiple factors place together in various models, health models. Because when we talk about, we just can't say it's only genetic. We can't say only it's social. We can't say it's only psychological. So what mostly is accepted is that there's a biological vulnerability, there's a genetic vulnerability, and social factors and psychological factors, all the adds on in an individual who is vulnerable, and gradually that vulnerable individual adds on to his profile. So if somebody is vulnerable and there's social factors which keeps on adding to it, and the person does and the psychological capacity is compromised, gradually it leads to a disease model. So this is what is usually understood. When we talk about, a lot of people say why we need to understand biopsychosocial model. We can't do anything for the biological perspective, yes, but we can work on the social and the psychological perspective. That is the beauty of this model, is that and that's why people are talking about a concept called epigenetics also. You work on the psychological factors, you work on the social factors, and gradually your vulnerabilities get settled down. That means you will not be exposed. You will be exposed, but still you will not be really exposed, because when your social capacity and psychological capacity are enhanced, you're able to take care of it. But then there is, though this model was developed in 1977, but then also there's a lot of criticism, because still people feel that you can't explain everything from the biopsychosocial perspective. It has its own limitations, and though it still continue to carry a lot of influence, but people still have a lot of shortcomings. And that's where the fourth aspect, which I want to highlight in next slides, is the next aspect comes is the spirituality. Now, what is spirituality? I'm sure if I asked around, I was counting the heads out here, around 80 people sitting in this lovely Gulmohar hall, and everybody will have a different definition of spirituality. I can bet you, everybody will have. So, trying to define spirituality is rather like trying to define yourself, your own self, and everybody has their own experiences. It can be like believe in a higher being, searching for a meaning of life, like a sense of purpose and connectedness. A sense of purpose and connectedness. So it's a very, very open and fluid concept. You can't define into a box. You can't say, okay, very, very rigid about it. You can't be. It's a very, very fluid concept. And the good thing about spirituality, it's a evolving and dynamic concept. What was my spiritual perspective 6 years back or 10 years back, and what is today in 2020 will be entirely a different ball game. And what will be in 2030, I don't know what I will be. That's what evolution is. That's what dynamism is. And that's what we keep on evolving in this. Now, and there is no one clear, comprehensive definition of spirituality in the literature also. The most fundamental concept of spirituality is that there is a transcendent dimension to life. Something or someone beyond the human ego and sense experience. Very experiential concept. When I started my journey, I never thought of that this is really spirituality is. And every day when I experience, I come to know, yes, this is what spirituality is. So it's a very experiential, the experience of connection to this larger sacred reality is what gives your life ultimate meaning. And that's what people are doing, because that's what people are into the journey. They want to look for that ultimate meaning. They want to look for it. When I talk to a lot of teenagers, they are not able to give you answers because they don't know themselves the answers. They don't know हमें पता ही नहीं, we don't know what is exactly we are looking forward for in life. Something is there, something beyond. But what is that something beyond? When I ask them, why, what makes you cut? When I ask them, what makes you take that blade and cut your skin? Why you wanted to have that pain? Why you wanted to see that blood? What gives you that kick? Why you love those scars on your hands? Why you want to disturb the natural process? Because we love it. We like it. And that is what way we get the kick. What is that ultimate meaning? That is where is that, and that is what the different. And then when we talk about different dimensions of spirituality that has been described, the meaning and purpose of life, transcendence, inner journey, interrelatedness, wholeness, lot of things, religion, mystery of creation, transformation, morality. So different dimensions are there. Now, one thing which also we need to little bit define is that the difference between spirituality and religion. It's a very overlapping in a common man's term. Religion, spirituality, it's this thing is there. But what I could understand is that in religion, it is an organized system of belief, practices, and symbols. In spirituality, it's a variety of activities, from religious to reading holy books to non-religious activities. It is spiritual, is something like inner, personal experience, again experiential, universal, without boundaries. That's a very important part. It's without boundaries. It's absolutely universal and without boundaries. You can connect with anyone. You don't need to be. It's a universal phenomena. It's largely free of the rules, regulations, and responsibilities. When I was going through this, one of the manuals on spirituality and mental health, if anybody's interested, can look for this. It's a lovely manual, lovely booklet on spirituality and mental health, which was brought out by the Indian Psychiatric Society in 2009 by one of the one of the people from Brahma Kumari, along with Indian Psychiatric Societies, Dr. Avdesh Sharma. It's a lovely book. It talks about various aspects. And when I was going through, one of the things which comes up in that book is, and the article by Coing et al., is what are the health benefits of spirituality. And one of the important aspects of spirituality is that it's extended life expectancy, lower cardiac problems, protection against depression and anxiety, reduced levels of pain in cancer sufferers, and increased success in cardiac surgery. That's where the spirituality comes into play. When we talk specifically about spirituality and mental health, why it is important more and more is because people are experiencing a vacuum in their life, which is called a spiritual vacuum. They're trying to find the answers which they can't get it, and that troubles them. They have everything in life, but still they don't have everything. They're looking for something which is unknown. That fear of unknown. We are living in a very chaotic world, very toxic world, I always say. Very highly toxic world we are living into. And when we are exposed to the toxic world, we want to know certain things. We don't know what will happen. So many unexpected things are happening. So much political chaos is happening. So much environmental chaos is happening across the world. And that's where people are looking for answers. And that's what creates them a vacuum. There's a spiritual hunger in this beloved world. And that's where the spiritual dimension is an essential and important aspect of health, particularly mental health. And when we define mental health, one of the most simple definition of mental health is a harmony within the individual and with the environment outside. And when we have a harmony within an environment outside, there has to be a spiritual aspect to it. You cannot have that harmony unless you have harmony within and with the environment. And for that, you need to look into the spiritual aspect. So the ideal state of mental health always has a spiritual connotation. And people who works in the field of positive mental health, I'm not talking about illness, who works in the field of positive mental health, always lay emphasis on the spiritual aspect of mental health. And when they work on that, there's enhanced sense of well-being. They're happy, they're contented. They decrease anxiety and depression. They have a different aura, they have a different smile, they have a different energy, improve memory and improve memory and better learning, tolerance of pain. And what happens at the biological level? There's improved neural plasticity, connectivity in the brain. The enhanced effects of psychotherapeutic interventions. One of the former ex-president of Royal College of Psychiatrists, her name is, I'm just slipping off from my head, she always said the spiritual aspect in the therapist and the client is always neglected, and it's worth looking. Transcendence of the personal identity, sense of purpose and new meaning of life. And it has been, enough studies are there that there's reduced psychopathology, reduced antisocial behavior, low rates of crime, alcohol and drug abuse. One of the famous person, Alan Rowland, who talked about that there are four parts of structural theory of the self: the familial self, individualized self, spiritual self, and expanding self. And a lot of times the spiritual self is neglected. And this spiritual self remains deeply engraved in the pre-conscious, especially of the Indians. And there's a positive relationship between the spirituality and mental health in relation to a number of mental health problems, such as depression, anxiety, schizophrenia, post-traumatic stress disorder, and substance abuse. As Dr. Lakshmi was talking about, how this model is practiced in the everybody the time they enter, the continuum of care, and how this part is very, very important. According to researchers, incorporating spiritual dimension in mental health will contribute to a more comprehensive model of care and research that takes account of the patient in the fullest wholeness. There are multiple ways. There can be multiple ways. I was struggling to put this into words, but then I got this document from WHO 1998, which talks about the multiple ways how you can enhance the spiritual quotient, SQ, in your mental health. By creating an environment for purposeful activity, by enjoying nature, by doing creative art, by exploring an environment for purposeful activity, by free time, and, and the second important part, opportunity and encouragement. This is where we struggle in today's world. To take out opportunity and encouragement to make sense of and derive meaning from experiences. We keep on having experiences, but we don't take out time, place, and privacy to have opportunity and encouragement to make sense of what we are going through. It just comes and go, comes and go, comes and go. Everybody is in a run. But we don't take a pause to understand what is we going through. Education of spiritual matters is very, very important. And it's not one day. Daily learnings, daily spiritual teachings. And that's what happens. And when you become part of it, it becomes engraved in your mental health. Encouragement in deepening faiths. The more you get into it, the more your faith gets deeper and deeper and deeper. The more you get encouraged into it, the gradually you're able to put all the puzzle together and says, yes, that is what it makes sense. That is where you get the whole holistic and the whole view is thing there. And then you feel universally connected. So these are some of the ways in which you can enhance and work on your spiritual perspective. There's some of the models, the 5 minutes now. There's some biopsychosocial spiritual models are there, different models are there, and which you can read about it. One talked about Anand Raja. What I want to address from this slide is that Anand Raja talks about three aspects of this multidimensional 3H model: head, heart, and hands. When he talk about the head, he's talking for that we are searching for meaning and purpose in one's life. When he talks about the heart, we are all looking for the love, inner peace, and resilience, the connectivity. And when we talk about the hands, we are talking about outward expression of the spiritual beliefs and needs, choices, behavior towards others, rituals, and practices. So there has to be synchronization, synchronization between all these three aspects. It should not be only in the head. It should not be only in the heart. It should be also in your hands, the karma. That's what. And then you get the spiritual attainment, the spiritual attunement. That's what happens. That's why a lot of times there's a disconnect between your head, your heart, and your karma. There are two models which talks about, fastly I talk about these two models, BMSEST models. I also read for the first time while I was making my preparations, but I liked really this model. It talks about the two models, the duality model and the unity model. In one single line I can say, in duality model, the God is seen as separate. So we all sitting in this place are like brothers and sisters. We all are souls, Atma. Everybody is like a soul, Atma, connected here. And there's one Paramatma, the God. And then when we talk about the unity model, everybody is one. So this is the two models. So in the first one, it's a separate and the God, and in this, it's a unity model. So but in both of them, the prayer, meditation are methods to connect with the supreme power or to be part of the system like an ocean in the unity model. Now, a lot of people have talked that bring your spirituality in your practices. And people have found that when you bring religion, when you bring, even the Royal College of Psychiatrists identified a wide range of spiritual practices and activities like compassion, creativity, equanimity, equanimity, honesty, hope, joy, patience, and perseverance that promote good mental health. Research studies suggest that spiritual activities, religious belief, intrinsic spirituality, spiritual healing techniques such as prayer are associated with mental health and well-being as well as improved health outcomes. From there, I want to take it a little bit to the clinical practice part, is that the spirituality of mental health professionals is very, very important. And that is very, very important because every day in and out, working with the mental health issues, we need to look into that how we can enhance our own spiritual levels. The spirituality of mental health professionals have great relevance to the clinical practice. The spirituality of mental health professionals can be a resource for facing the stress and the challenges of the profession because there's a lot of burnt out there. And we know in mental health professionals, there's one of the highest rates of suicide across the world in mental health professionals. So it will help us not only preventing burnt out, but also improving the job satisfaction. Many psychiatrists use religious and spiritual teaching as basis for treatment of the patients and promoting community mental health programs. When we talk about depression and spirituality, the main feature of depression is a transient or stable loss of meaning or purpose of life. What Cohen found out that for every 10-point increase in a person's intrinsic religiosity, there was a 70% increase in recovery from depression symptoms. A strong negative association was observed between the Facet Spiritual Wellbeing Scale and the Hamilton Depression Rating Scale. What is also found that anxiety was more common in those who did not use positive spiritual coping mechanisms. Spiritual affirmations, whether religious or existential, may buffer the effect of violent trauma. So how the spiritual care benefits is improve the self-care, control. You feel in control. The intrinsic locus of control, Usually we tend to have an external locus of control. When the spirituality brings an internal locus of control. The self-esteem enhances, relationship with self, others, and the God improves. And the most important thing which you see, the foresightedness, a sense of meaning, resulting in renewed hope and peace of mind and enabling people to accept and live with their problems. So in conclusion, spirituality is a universal phenomena, characteristic of human wholeness. Spirituality and religions are often used interchangeably, although they are arguably different. Researchers generally consider spirituality or religion to be a multidimensional concept in that it consists of multiple domains. What I want to emphasize is that spirituality has been found to correlate with positive mental health and positive well-being. Studies have indicated in general the positive role of spiritual beliefs, activities, and experiences in promoting mental health and psychological well-being. Considering that spirituality has associations with mental health, it should be considered in research and clinical practice. And longitudinal studies will be useful in understanding the complex interplay between spirituality, religion, and mental health. In the end, saying thank you is more than good manners, it is good spirituality. Thank you very much. Om Shanti.
Thank you, Dr. Deepak Gupta, for sharing your own spiritual practices and also for highlighting really mental health of the mental health professionals as well. The biopsychosocial model, the ability to not only see the interconnectedness between these various dimensions, but also seeing how spirituality can feed right back into physical health, into mental health, into decreasing symptoms and symptomatic behavior. And most importantly, for connecting that back with really all of us finding meaningful ways of engaging and thereby increasing our spiritual quotient. It was also reassuring to hear about similarities about transcending self, which we heard about yesterday as well. So thank you very much for that insightful talk. We are going to now hear from Ms. Ragini Chopra. Ragini has studied applied psychology at the University of London and thereafter specialized in stress management with a cognitive behavioral therapy approach. She has received additional and extensive training in therapy during the many training courses that she has attended. Ragini is a qualified, accredited, recognized, and awarded counselor based in London with significant experience and success working with individuals across many diversities and personal challenges. Her counseling work includes private practice, counseling services, and employee assistant programs. She primarily offers cognitive behavior therapy and does assessments. Has been receiving excellent feedback and appreciation from her clients and supervisors. What I would like to add about Ragini is she's going to bring to us something very special, which is really a cross cultural context. Since she's currently practicing in the UK, she also began work here in India many years ago, where she worked for a suicide prevention helpline. So we're really looking forward to your talk, Ragini.
Dr. Nivedita if there were facilities for a presentation. And she wrote back saying, "This conference is formal by Indian standards, so you will have an auditorium with all the presentation facilities, but it's not as formal by Western standards. It has an Indian, Tibetan, warm sense to it." Thank you very much for your warm welcome. I'm truly honored to be in the presence of Venerable Geshe Dorji Damdul, and thank you, Dr. Nivedita, for inviting me. So I'm going to talk about a really, really difficult topic, which is the use of assessments for recommending therapeutic interventions. It is a topic that's evolving. It has so many different aspects to it. And to bring all of them together, you need a lot of experience. And so I'm going to make a small start by going to the agenda. There's an introduction, and I'll bring to you the available psychotherapies that are in use in England, and their views, aims, and their uses. And of course, you need to look at clients' preferences and suitabilities as well. And then, how do you find all this in an assessment and come to a good recommendation? And then the Indian cultural perspective. So, here's the start now as an introduction. 1 in 4 people are affected by mental health problems. I know it's statistics, but it's good. It brings to you the sheer numbers. And people seeking help have multiple therapy options. You've seen over these 2 days itself how many options are available to people, and there's so many more. And an assessing therapist can help by recommending the appropriate therapeutic approach. And a lot of this can be found out from an assessment, which I will go through towards the end of this, the 20 minutes. And of course, the knowledge, skills, and experience of the assessing therapists are important to arrive at a helpful conclusion. So to make a start, I know a lot of these therapies have been talked about already, but these are the main approaches that we use in England. Of course, starting with the medical intervention, there's psychodynamic therapy, there's cognitive behavioral therapy, there's a humanistic therapy, integrative therapy, and the other therapies. Medical intervention, and of course, Hippocrates, he's the father of medicine. And what are they saying? They're saying there is a chemical imbalance. And it's usually the first approach by doctors and is primarily using drugs. There are some kind of mental disorders that when both the medic and the psychotherapist work together, it's useful. And what we found is that this is in severe depression, bipolar, schizophrenia, substance abuse, personality disorders, eating disorders, self-harm, and high-risk clients. Next, psychodynamic therapy. And of course, Sigmund Freud, he's the father of psychoanalytical therapies. And psychodynamic is a little bit more, a little evolved. It's less intensive than psychoanalysis, and it focuses more on immediate problems and quicker solutions. And what are they saying? They're saying the unconscious holds onto painful feelings and memories, and it's making the unconscious conscious. That's the aim. And it's often used in treating anxiety, addictions, eating disorders, personality issues, relationship issues, psychosomatic illnesses, depression. So this is one of the first therapies that came into being in the Western context. And then we move into cognitive behavioral therapy, and this is what I practice. Of course, the start is behaviorism, there's Pavlov, there's Skinner, and what are they saying? They're saying behaviors can be learned, so they can be unlearned. And then you have the cognitive theory where psychological distress is caused by distorted thinking. And you have Aaron Beck and Albert Ellis. There's he's cognitive therapist. He's REBT therapist. I think there's somebody here who practices REBT. So yeah. Then we have cognitive behavioral therapy, which is it's a combined approach of behaviorism and cognitive therapy. And what are they saying? They're saying thoughts, feelings, physical sensations, and behaviors are interconnected. So if you change some unhelpful negative pattern, it'll cause a change in that cycle that goes on within you. And it's a very here and now problem solving approach. It teaches useful skills, and it can be completed in a short period of time. And of course, there's the third wave now of CBT, which is MBCT, CFT, ACT, DBT. And here there's a lot of Eastern influence. It's you have a mindfulness that comes into these therapies. So this is being now in the third wave of CBT, what we call there now. It's often used in treating depression or anxiety disorders, panic disorders, phobias, OCD, PTSD, bipolar disorders, problems related to alcohol, sleep problems, eating disorders, borderline personality disorders, and schizophrenia. And then, of course, we are now into Carl Rogers and person-centered humanistic therapy. And this deals with the way people perceive themselves consciously. It is not the unconscious of Freud. This is how people are perceiving themselves consciously. And it says that people have innate tendency to develop their full potential and self-actualize. And this ability can become blocked or distorted by life's experiences, and people utilize their own strengths and personal identities. And there are three conditions for the therapist, which is unconditional positive regard, empathy, and genuineness. And it's often used in treating grief. I've noticed myself, I work as a CBT counselor, but if I have a client who comes in with needs where I feel CBT is helpful, and they shift to grief, then CBT, I don't hold CBT in the session anymore. I have to remove it, and then I have to get into this approach, because this is where this approach is going to be helpful for grief, not CBT. So to be aware how different therapies are helpful in treating different kind of disorders is useful, because sometimes you have to shift in the session itself from one approach to the other, depending on what is suiting the client, what is suitable or helpful to the client at that time. Then we have the integrative therapy. And of course, it says that no single approach can treat each client in all situations. and is bringing together elements of different therapies. It tailors therapies to clients, not client to therapy. And it tailors to many needs and concerns. And of course, there's anxiety, phobias, past and current trauma, depression, bereavement, addiction, low self esteem. And there are other therapies. There's group therapy. It can be person centered, psychodynamic, transactional analysis, CBT groups. Of course, groups, the benefit of this is that you can put a lot of people together and it's cost effective. But also, on the other hand, I find sometimes clients come to me who have been part of groups and they say, well, I was in the anxiety group, but I didn't think the other person had the same anxiety I had. So they kind of feel I lost out somewhere. I need that one to one, that group, although it had a common theme, that my fellow client didn't feel or sense anxiety like I did, and therefore it wasn't that helpful. But on the other hand, it does also, in limited resources, give a lot of information and support to groups. Then we have complementary alternative therapies. A lot of dissatisfaction with conventional medicine had led many to seek help elsewhere. And this can be used in addition to conventional medical practices. And it treats a whole person, especially by stimulating body's natural and self-healing abilities. But of course, in the West, it can be controversial due to the non-scientific nature of the claims. So let's come to this interesting bit now, because we have already covered the main therapies, what they offer, where they are used. Now we have the client there. And what is the client bringing? Because you're trying to match the therapy with the client. We have talked about therapies where they're useful. What is the client bringing? Psychodynamic, it can be suitable for everyone. It could benefit people with curiosity to explore themselves. If somebody comes and tells me, I have an issue, but I want to know how did this all start? I want to explore what happened in my childhood. I'm not going to take him to CBT. CBT is saying now, here and now, this is where you are present. Where do you want to go? But he doesn't want to be there. She doesn't want to be there. They want to go to their past. They want to see, how did I become like that? Why did this problem come up for me? So you need to hear what the client is saying also to match them with the relevant therapy approach. And of course, there's a desire to relieve their symptoms. And this is really important. They need to have a capacity for self-reflection. If the client is just, he's just talking, he's not interested in reflecting what's going on, is he psychologically minded? If that is an issue, it could be a bit of a problem offering psychodynamic therapy to them. And CBT, of course, focuses on the person's capacity to change themselves, but it needs you to be committed to structured CBT sessions and doing homework and having an awareness of your thoughts and emotions, because that's critical. We start working with your thoughts, and if you're not being able to I don't know what I'm thinking. I don't know what I was thinking. If those are the kind of things coming up, then there is something you need to consider, that do they have access or awareness to their thoughts and emotions? And probably not suffering from very complex mental health needs. Then you have the person-centered approach. It helps people of all ages and personal issues. It allows control over content and pace of sessions without feeling evaluated or assessed. Because the first two are a bit more structured, they're more led by the therapist, but the person centered is very much led by the client. And it benefits those with a strong urge to explore themselves and their feelings. And however, it's less effective the client wants active and directive therapist. I've had clients who come and tell me who've come from a person-centered approach, and they'll say, "Oh, that didn't work for me." So I said, "Why?" "She didn't give me any advice." So, well, that therapy is not a therapy to give advice. So, what is the client looking for? This is something you need to consider when you're matching the client to the therapy. Then there's integrative, and of course, it can be helpful to clients with many needs and concerns, and it allows for the use of different approaches tailored to the person's needs. Uh, just to bring in a few more things, psychodynamic and CBT can be a bit, there could be a bit of exclusion, because when you see a client and you feel they're not psychologically minded, it could be difficult to, or may not be useful to offer them these two. Uh, the bottom two are very inclusive, because there are not too many things that you need to check with the client's abilities to offer them these two therapies. And of course, mindfulness is a lot now part of CBT, and it doesn't label people, it's inclusive. However, it's sitting with CBT now because there are gaps in CBT. And what I find now in England is, where there are gaps, we are accepting what is research, like John Kabat-Zinn has researched mindfulness and it feels right. And so it's brought into CBT as part of what is offered in CBT. So, yeah, there are some other interesting aspects I've noticed that, as a practitioner of CBT, I notice when the young come, they take to it so well. They come with their mobile phones, whatever we work on, they take pictures. They're very excited with CBT. And I feel the older lot, I've had clients who are 80 plus, they take a session or two to get into accepting, what is this? What are you saying to me? So it takes them a couple of sessions, but then they start getting into the flow of it, and then they're helped very well as well. So the next one is, what are the key considerations in assessments? The important considerations would be clients presenting issues, their goals for counseling, previous therapy and how useful it was, any previous medical intervention, health, physical issues, medication, alcohol, risks, family dynamics, and the observation of the assessing therapist, because he's or she's noticing, was this client psychologically minded? What were they saying? So it's the observations of that assessing therapist. And practical consideration, who are they referred for? I mean, I have clients who come from universities, 6 sessions. So you've been told that this is what they're going to pay for. Counselor preferences, availability of time. So then you make your recommended approach and your rationale for the recommendation. So I'm going to give you a very quick a kind of study, case study. There was a young male student, 20 years old, and is presenting issues. The presenting issues was anxiety and procrastination. And what did he want? He wanted to overcome his anxiety and procrastination. He wanted to function properly so he could get his best grades. And he didn't want to be limited by his previous cognitive deficiencies, is how he mentioned it. And previous therapy had a mentor before. He used to drop in. There were no real risk issues out there. The observation was very articulate, and he gave precise and detailed answers. And so he was referred by university. 6 sessions were already fixed for him. he requested CBT because he said that his well-being advisor at the university had recommended that, and he would like concrete steps to change his thoughts. And we found a CBT counselor that went well with him. And the rationale was that he requested it and he wanted a hands-on, concrete approach to change his thinking patterns. And what we found was that over these sessions, his anxiety fell from 9 points to 2, and he was not procrastinating in 6 sessions. And he said these sessions changed his life for the better. So just to see that when the recommendation of the therapeutic intervention is accurate, it can be very, very useful for the client to be helped in 6 sessions. So, okay, I've been told time is running out. Indian cultural perspective, much of this is relevant. However, this is some of my views. There could be challenges and opportunities due to adequate systems, institutions, and regulations concerning mental health. Certification or accreditation of qualified and experienced mental health therapists. How do you recognize somebody's got the enough education, experience to call themselves what they're calling themselves? Confidentiality issues, commonalities and differences in defining and treating mental disorders. It's not always the same. And in the end, is there belief in the Western model in the Indian perspective? And which is more desirable? It's a choice to be made. It's not necessary the Western model is the best model. So multiple therapy options, appropriate therapeutic approach needed, knowledge, skills, and experience of the assessing therapist. And this is a challenging and rewarding career. Thank you very much, everybody.
Thank you very much, Ragini, for bringing in both perspectives as well as the awareness and an overview of all kinds of existing therapies. And I think the matching of therapies with illness symptoms that it would work best with, whether it was psychoanalysis, CBT, and so on and so forth. I really also appreciate the comments about client preference and suitability. Because that becomes an opening for kind of saying, does this match with what I have to offer as a therapist or a practitioner? So that was really insightful. Thank you. I think we have about 8 to 10 minutes left, so maybe we can take 2 questions or 3 behind
you. Thank you, Dr. Deepak Gupta. My question is, the word, the spiritual, has been very enigmatic to me till now. Because when we are saying physical, I can correlate. When we are saying mental, I can correlate. But when it is said spiritual, what is the correlation or the reference of that word? If you could little bit concretize that. That is one. And the second is, you mentioned about the spiritual quotient. As the life progressing, I think when I was studying in the university, there was the IQ, intelligent quotient. Then it moved to the emotional quotient. And now the people are talking about the spiritual quotient. I think you have referred WHO mentioning that. In the case of the first two, there's a kind of measurement framework. What is IQ, how it can be measured? What is EQ, it can be measured. Is there model to measure the spiritual quotient? Thank you.
I wish everything in life could have been measurable. There are happiness questionnaires are there, questionnaires to measure happiness. There are questionnaires to measure sexuality. There are questionnaires to measure quality of life. And yes, there are questionnaires to measure spirituality quotient also. One of the studies which I mentioned, FACIT, FACIT, did use the spirituality scale. And there are enough scales are there. You can go to this document by WHO 1998 and further more references. There are enough scales are there. But as I mentioned, that spirituality is an open and fluid concept, and it's an evolving concept, what is said. And I'm sure some more questions will come up in the next more decades as we grow up and have more white hairs. My point is that your question about correlates of spirituality, it's very difficult to put into few words, but yes, I think it's one thing which I can say, it's a very experiential phenomena. It's exploration of self and relating yourself to the outer world. And simultaneously, which a lot of people have taught, that finding the ultimate meaning of life. Correct. For me, it may vary. For His Holy Highness, for him it may vary. For Dr. Nivedita, it may vary. Yes. So it varies with people to people. So exact correlate I cannot say, but yes, to the few dimensions which I can say, which I've also highlighted, is that it varies person to person. I wish I could have a simple answer for you.
I have a, sir. Hello, sir. I have a regarding to you. I have a question, and you have mentioned about the being a spiritual, and I'm thinking, wondering, like, if like being a spiritual means like liking doing something which you like, or some like doing something which you like. If like as someone like me, I don't know what to do, what in my life, I don't know even want to do something, but I'm not understanding what I like. So in these cases, how can be a being a spiritual like something to understand whether there's something which I like or not? How can you like explain? Sorry.
See, I didn't highlight it deliberately, that point, because one is shortage of time and it's an open Pandora box. It's everybody can have different ways to attain that. And it depends what school of thought you want to follow. For me, it's Raj Yoga. For some people, it may be Buddhism. For some people, it may be something else. So, at this point of time, when you say you're struggling with your own self, that means itself that you're trying to explore spirituality. That's the beginning, according to me. So now you need somebody to handhold you. You need handholding. So you need to be part of some group, or you need to be part of some learnings and teachings where you start exploring and reading about it. And once you start reading about it and start practicing on a daily, regular basis, consistently, gradually you start getting the spiritual enlightenments. And then you start believing into those values and practicing in your life. You start inculcating in yourself. When you start inculcating in yourself, you start getting the meaning out of things which you were not getting out of it. So those things start giving you the roadmap. It's a journey. That's why people talk about spiritual journey. It's a journey, and it's evolving journey. So when you are thinking about this, that means you're on the right platform. Take it forward. Take it forward. And start becoming a part of the group, wherever you are. And then gradually you start going into it. The more you go deeper into it, as I told about the faith goes into it. The deepening of your faith goes into it. And then you start getting meaning out of it. That is what is it. Correct? Please.
Pardon me for walking into a terrain which frightens me. But as you were talking, I was just thinking, and I might not have the right answer, but I'm thinking of paths of connection in terms of the way I see spirituality. And just to elucidate, since you're a young girl, it's evolving, as Doctor said. Today it could be my connect with my garden. It could be my connect with my food and my cooking. It could be my connect with my pet. So these are connections. And generally I don't like to layer connections as being inferior or superior, because connections can get extremely, from young people, concrete to abstract. So I think if you're in search, the Khoj, for these kind of multiple connections through people, through networks, not necessarily organized. If it's an inquiry that goes on, I think I'm not answering this question on how do I become spiritual, but how does spirituality and I experience each other? That's what I'd like to share with a lot of young people here who are always searching. We are searching, including me, I'm young. Thank you.
Thank you.
It's a never-ending hunger. It's a never-ending hunger. That's what people have called spiritual hunger.
And it's very inspiring to find the questions being asked by someone as young. And really, I think on behalf of everybody, we just urge you to study and explore and really learn more, because we're living in a very rich environment which is asking these questions so that you can find your own path. We'll take one last quick question. Yes, please.
Thank you very much for a very enriching session. I just have some observations for all the speakers today. So, first for Dr. Lakshmi, ma'am, I think when you talk about home and homelessness, I think it's a very complex issue. People living in homes can feel homeless, and people who are homeless can actually feel at home. So, we need to look at that perspective as well. And for Dr. Deepak Gupta, sir, when you talked about harmony with the socio-cultural environment, I am a bit suspicious about it. Because when you want to bring about change in societies and cultures and in people, you need to be a dissenter. You cannot be in harmony with your environment. Only then the change comes. So maybe you need to think about that. The role of, being a dissenter in one's life. And Raganiji, I am a bit concerned about this whole, matching of the therapy and the patient, because you need to keep in mind the political economy that is behind it. There's a lot of politics and there is a lot of money issue involved in it. So how do you handle that question? And there could be also the factor of class and gender, so many other things. But basically, political economy, I think, is very concerning for me. Thank you.
I just want to say one thing. Thank you very much for bringing this important point. Harmony and inquiry. You can have a lot of inquiry about things. You can have a lot of inquiry about your own self. And each inquiry gives you certain aspect and perspective and makes you more and more harmonious. It's an ocean. Harmony is an ocean, according to me. And as you get more and more inquiry, you get more and more deeper into those inquiries. You get more and more spiritual enlightenment. That hunger doesn't stop. And every inquiry gives you another inquiry. And then you get more and more harmonious with self and the environment. That is what I could understand at this point of time in my life. Maybe I may have a better answer a decade down the lane. Thank you very much.
Thank you, everybody. I think the panel has been left with a lot of areas to think about, because really we looked at 3 dimensions of not just a client, but a client in a particular context. And of course, the context of the therapist or practitioner themselves, and really looking at how those 3 match, don't match, what kind of questions need to be asked. Immense gratitude to all 3 of the speakers. Thank you very much, and all the participants.
And thank you so much, Dr. Nevi.
Thank you very much.
Dr. Nevi and our panelists for sharing your profound knowledge and wisdom. So before concluding the session, I would like to request Professor Renukaji Singh, Director of Tushita Meditation Center, Delhi, to kindly present the souvenirs and khadas to our respected chairperson and panelist. Dr. Nevidita. Dr. Lakshmi Ravikant ji, Dr. Deepak Gupta ji, Miss Ragni Chopra, thank you, Professor Renuka. Thank you all. And next, kindly be seated. We will continue to the student panel discussion. Thank you.